Let's continue with ventricular arrhythmia. We said that the individual must have 3 PVCs in a row to consider this an arrhythmia. And usually these PVCs are about longer than 120 milliseconds. The clinical presentation for this is that the patient will present with a lot of signs and symptoms such as congestive heart failure, hypotension, syncope, cardiovascular arrest. They may present with signs and symptoms of shortness of breath. You may see a Cannon A wave jugular venous distension, and they may have a widened split S1 and S2. Ventricular arrhythmias, we have two that are heavily tested. Obviously, we have ventricular fibrillation and ventricular tachycardia. In here, we're showing you the images of both the fib and tach. In the fib, you see that there's completely no way to discern what's going on here. You can't tell the P wave, the QRS complex, you can't really tell. Everything looks like a complete disarray. That's how you know this is V-fib. On the other hand, V-tachy, it depends on the type of V-tachy. You have narrow QRS complex and you have wide QRS complex. This particular V-tachy here is wide QRS complex. And the reason why I put that there is because the treatment options would depend on the type of V-tachy there is. Let's talk about V-fib. In V-fib, the most common etiology for V-fib is that the individual will present with signs and symptoms of ischemia. They may have an MI or they may have cardiomyopathy. In addition to ischemia being the most common cause, we know that there are a subset of other signs and symptoms you see that may clue you into thinking this person has ventricular fibrillation. They're called the 5T and the 5H. Now, you don't have to memorize this. Essentially, when these things are happening, there is an effect on the electrical activity of the heart, and that can lead to the arrhythmia we see. But it also helps if you kind of put this in the back of your mind, because when you read your clinical vignette, one or two of these things may give you a clue to the fact that this person has some form of arrhythmia. The 5H are person who has hyperkalemia. Hyperkalemia, of course, of all of them, you must memorize hyperkalemia because that happens frequently and it's frequently tested. Then you have hypoxia, you have hypoglycemia, you have hypothermia, and you have hypovolemia. So all these things may affect the heart in some way, shape, or form that lead to an effect on the electrical activity, which can cause the arrhythmia. The 5 T's are important. You have tension pneumothorax, thrombosis, tamponade, toxin, and trauma. All of these T's may have an effect. But again, these are supportive things that are given in your clinical vignette. So you don't necessarily have to memorize it. If the person comes in and they had blunt thoracic trauma by the steering wheel after they went into a car accident, then you can say, okay, maybe that caused a cardiac contusion and that led to an arrhythmia. So you can piece that together, but you don't necessarily have to memorize this. Let's continue. The clinical presentation for ventricular fibrillation is such that the person, to my definition, this is a dead person with an EKG. It's just that simple. The person to me is dead and they have an EKG. Now, it is not the scientific dead where the brain waves is gone and everything is gone. To me, I just saying the person is dead. So when you think that way, you make it simple. Person is dead with an EKG. So when you look at an EKG of a dead person, it looks crazy, all right? And so then it's easier for you to know what to do next when you see that. The diagnosis can help you easily by looking at the EKG. You see that it looks crazy. No normal person has an EKG that looks like this. Then you will think about management. The management, V-fib, D-fib. V-fib, D-fib. Whenever a person, you consider them to have ventricular fibrillation, defibrillation. The defibrillation will allow for you to rescue the SA node and give the person back their rhythm. I think they're dead, and you rescue them by shocking them. So then after the person is rescued, what do you do then? You place the person on what is called a hypothermic protocol. Essentially, you want to lower their body temperature to about 93 degrees Fahrenheit, and basically you continue with the supportive therapy from there. This person will likely be in ICU for a while. Then you talk about complications of this. Complications of this, the person may have anoxic brain injury. Why? Because I believe that they were there and you shocked them back to life. So therefore, all the vital organs will probably shut from getting blood supply. The brain is especially important in that it only has about less than 5 minutes before things start to shut down in the brain if it doesn't receive oxygen and blood supply. So they're likely to get anoxic brain injury. And if there's a recurrency of this, that can lead to death. So let's talk about ventricular tachycardia, from which the bulk of your question will come. In ventricular tachycardia, again, just look at the EKG and make sure you can discern some kind of a QRS complex here. You can't really see the P wave because the P wave is buried underneath these wide QRS complex. But you know there's a QRS complex here, so you know this is not fibrillation. In the etiology for ventricular tachycardia, is that you may see a complex tachycardia, no P wave, and you see it looks uniform. You see that it looks uniform. This is widened uniform VTach. Ischemia is the most common cause for VTach. Just like VFib, ischemia is the most common cause. Then you have things like prolonged QT syndrome, which we will talk about, and the drugs you need to memorize, a handful of them that causes prolonged QT syndrome. First, let's talk about electrolytes' effect on the prolonged QT syndrome. Hyperkalemia and magnesium and chloremia. Hyperkalemia and magnesium and calcemia may affect the QT. Remember, from the QRST, that whole process is a depolarization of the ventricles. So that process requires a balance of potassium exchanges. It requires a balance of calcium exchanges. So cases where there's more potassium, there will be more influx of potassium. That's going to prolong that process. So it's more likely to get tachycardia. Calcium can do the same thing. So it's important now to memorize certain drugs that may cause that electrolyte disturbances. The most common drugs are certain class of antiarrhythmics, and then we have some miscellaneous drugs here. Let's talk about the class of antiarrhythmics that causes this. We have class 1A, 1C, and class 3. Class 3 is important to know because there's a drug in class 3 antiarrhythmics that's always given in most of the arrhythmic cases, and then class 1A and 1C is also important to know. Let's talk about class 1A, the most common drugs. Quinidine. Quinidine is a drug that's class 1A antiarrhythmic drugs, which is a sodium channel blocker, and it most frequently can cause prolongation of the QT interval. You have procainamide. Procainamide is also part of the class 1A drugs, can cause prolonged QT interval, and you have flecainide, which is part of the class 1C drug that may cause prolonged QT interval. Then you have class 3. The most common cause of the class 3 drugs are essentially dealing with sotalol, which is a beta blockers, but it's part of the class 3 category, and amiodarone. That is the gold standard and like the holy grail of antiarrhythmics. Then you have some miscellaneous things that may cause prolonged QT syndrome. You have erythromycin, which is antibiotics, can cause it. You have fluoroquinolone drugs, like the fluoxetines and such. They may also cause this. You have TCAs. TCAs, let's give it a gold star, is extremely important because TCA overdose can cause a lot of things. It can affect the CNS system, it can cause coma, it can cause all this, but it's very cardiac toxic. Then you have antipsychotic drugs can also cause the prolongation of the QT interval. Torsades de pointe is the resulting pathology, is in French for twisting of the points. So if you look at the QRS complexes in the reading, you may see some QRS complex may have high amplitudes and low amplitudes, and that looks like a twist around a central axis, and that's the definition of torsades de pointe. We will talk about it in its own very section. A person who has VTach would tend to have signs and symptoms of congestive heart failure. They may have hypotension. They may have signs and symptoms of syncope. That's part of the clinical presentation. In terms of diagnosing this, of course, you're going to do an EKG. You do an EKG and you see what you see on the EKG. You can do drug level, you can do CBCs just to make sure that this is not induced by some drug that the person is on. But you can also do a very nice history and physical and be able to get as much information as possible from their history. In terms of the management, you know that a person who has ventricular tachycardia, you have to group them into different categories. Do they have a pulse? Are they pulseless? Is this something that has happened on a long term? So do you need to restructure your treatment plan? Let's first talk about a person who has a pulse and they have ventricular tachycardia. In these individuals, essentially, you have two things to consider. You can consider synchronized cardioversion, and synchronized cardioversion, which means you're doing electrical cardioversion, or you can consider chemical cardioversion. But that would depend on the person's hemodynamic stability. Okay, so first, they have signs and symptoms of VTach. You see down the EKG. Then you ask yourself, do they have a pulse? It's very easy to find a pulse. Simple. It takes a few seconds. Then you ask yourself, are they hemodynamically stable? A person who is hemodynamically stable, you find an IV access and you pretty much go down your ABC. Okay, find an IV access, give them IV fluid, and you just consider what you're going to do in terms of treatment. And that treatment, again, as I said earlier, the type of morphology of the QRS complex determine the type of treatment. So here, when you look at the EKG, which is something you've done early on in the ER, you see that does it have a narrow complex or does it have a wide complex? Narrow complex EKGs will be given adenosine. So if you look here, this is an image that's showing you that this person has VTach. You can barely see, you can't even see the P wave here, but you can see the QRS complex. It's very uniform and it's narrow. And in such an individual, you know they have a pulse, they have ventricular tachycardia, the heart rate is so fast here, about 150 beats per minute. Then what do? You just give them adenosine. On the other hand, you may see that the person has VTach and they have a wide complex EKG, which we showed earlier here. If you see here, this is wide complex. It's uniform and it's wide. In these individuals, you will give a combination of drugs, which I create a mnemonic called SLAP, S-L-A-P. What does SLAP stand for? So SLAP is a mnemonic I created. Stands for sotalol, lidocaine, amiodarone, prokinamide. These are the four kinds of drugs that you may give to a person with wide complex ventricular tachycardia. The most common that is given on your clinical vignette is amiodarone. So memorize amiodarone. But if they do not give you amiodarone, lidocaine will be more likely the second choice they will give you. And if they don't give you lidocaine, the third choice will be prokinamide. Prokinamide is most frequently used when we deal with Worth-Parkinson-White syndrome. That's where usually they will test you on prokinamide. But for the most part, dealing with wide complex ventricular tachycardia, watch out for lidocaine as a drug of choice, or amiodarone. Amiodarone is so simple and so easy, everybody picks it. So most likely they will test you on lidocaine, but no amiodarone as the default. Then these individuals, you can consider electrical cardioversion as well. Now, giving these drugs are essentially chemical cardioversion because these are major antiarrhythmics. Then we say if the person does not have a pulse and they have ventricular tachycardia, again, this is to me a person who's dead. Okay, no pulse, ventricular tachycardia, so the person who's dead with electrical activity of the heart. So then your treatment plans is a little bit different here. In these individuals, they do not have a pulse. You shock them. It's just like when you want to give energy into something that you don't think has energy, you find a source of energy and you imply it. So if a person has VFib, you apply energy. A person has ventricular tachycardia without a pulse, you apply energy. So VFib, defib is the same thing here. Ventricular tachycardia with no pulse, you defibrillate them. Long-term treatments for ventricular tachycardia, essentially the most important ones that are given is beta blockers. Again, beta blockers needs to slow down the heart rate. Now the individual had a heart rate of about 150 beats per minute. We say anything above 90 is considered tachycardia. So at resting state, 150 beats per minute is too fast. So you want to give beta blockers to control it. And in severe cases, you may consider giving implantable devices. These implantable devices can be given in most cases where the ejection fraction is less than 35%, and they are called the AICE. So in the case where you think this person has a recurrent chronic ventricular tachycardia, so read your clinical vignette and make sure that they're talking about ejection fraction that's less than 35%. They might say 30, they might say 25. So you know you have to give something in the heart that will periodically shock the heart when it goes through some form of arrhythmia. Complication for ventricular tachycardia. In these individuals, you essentially can watch out for what is called torsade de pointe. This is the French for twisting of the points. So if you look here, we see that these are uniform type of slightly wide complex, and then they become disarray here, and then they're uniform, but the amplitude is higher here, and then again the amplitude is shorter here, but it's still uniform. If you look at all of this, for the most part, they're uniform. So you're thinking this is tachycardia. But if you were to draw a straight line through this here, you can tell that there's a twisting of the axis. They're going in kind of a sinusoidal wave type pattern. So this is dealing with torsade de pointe. In torsade de pointe, the most common etiology for torsade de pointe is that a person who has an abnormal ventricular repolarization and or people who have signs and symptoms of prolonged QT interval. So think about the drugs that may cause it. Think about things like prokinamide, we talked about, quinidine, can cause prolonged QT interval. So the drugs, again, here we say we have antiarrhythmics, class 1A, we talked about prokinamide, quinidine. Then you have antipsychotic drugs such as lithium or TCA or phenothiazine. Then you can have also electrolytes that may cause this. We talked about potassium and magnesium as causing torsade de pointe. You also have the mnemonic that people like to memorize, and again, you can memorize it. It's not so much how you have to memorize it, but it's here. It's called points. Just like in the name, twisting of the point or torsade de pointe. You have phenothiazine, you have other medications such as TCA, you have intracardial bleeding, you have idiopathic causes of it, you have type 1 antiarrhythmics such as quinidine and prokinamide and disopyramide, which is the third of the type 1 antiarrhythmics. You have electrolyte disturbances such as hypokalemia and hypomagnesium, and then you have syndrome of prolonged QT syndrome, aka long QT syndrome. This is more of a genetic cause that happens and it's idiopathic. The management for torsade de pointe as something that causes the prolonged QT syndrome, it's likely and it's heavily tested. You give IV magnesium sulfate. IV magnesium sulfate is high because it has a crossover to OBGYN when you're trying to treat for preeclampsia or eclampsia symptoms. That's why it's important. Individual can also get proterenol, or they can give lidocaine as a form of treatment as well. If we remember, we said that all individuals who are unstable must be stabilized first before you do anything else. And stability revolves around you doing your ABC, making sure the airways and the breathing and the circulation, all those are checked before you do anything else, any other modalities. In the case of cardiovascular system, any individual who is hemodynamically unstable with cardiovascular complaints, you have to cardiovert them. That's one of the major ways to stabilize them. And then, of course, in most of these individuals, you have to replete their electrolytes, the potassium, the magnesium, and you may consider giving them cardiac pacing.